Welcome, everyone.
Ooh, we're we're very loud. All right, I'll stand back a step. Um, Thank you all for being here. I know we've got some folks online as well. I'll start with some introductions. I'm Sarah Brewer. I co-direct our training, education, and mentorship program at Accords, and I want to welcome all of you today to our inaugural Accords highlights. Over the last year, we've had several changes in our educational programming at Accords, including integrating our education work with our training and mentorship programs under our new team core. And as we've been reflecting on our successes and planning our future directions for the team core, we identified a key and ongoing need to share the stories of our Accords investigators for us to learn from each other and to share that work out more broadly on campus and nationally. And so we dreamed up the Accords highlights. And we truly want this to be a space where we are highlighting and sharing the methods and tools that Accords investigators are using, the way that we are innovating in health services research and T3 and T4 science, and most importantly, to share the impacts that our Accords investigators research are having on health and well-being of people across clinical and community settings. So each quarter, moving forward, we will highlight two Accords investigators and the work that they're doing. We will share lunch. We hope that this will become a space where people can come and get to know Accords, share a meal with us, and meet others who are doing work in that T3, T4, and health services space. I have now said Accords about 30 times, but let me share out for those of you who are new to us what Accords is. So Accords is supported by the University of Colorado School of Medicine and Children's Hospital Colorado. And it's really a unique one-stop shop environment for faculty who are conducting pragmatic research to receive various types of supports and services for their grants, their projects, and to receive incredible mentorship, training, and education in health services research. So you can see several of the kinds of services that we provide at Accords here, and I really want to highlight particularly our training, education, and mentorship core as a great space to get several of those services to grow careers and move from some of those really initial steps of starting a research career to building a research program. And then I also want to highlight our practice-based research core because a lot of the work that you're going to hear about today is conducted in real-world practice-based settings and wouldn't be possible without both that infrastructure within Accords and the Department of Family Medicine, as well as the practices who agree to partner with us and let us come into their settings. Before I introduce our two speakers today, I just have a couple of housekeeping items. First, for those of you who are online, please use that chat liberally. We hope to hear from you. We want to hear your comments and your questions. And we will have time today. So we have our structure is that we'll have two approximately 20-minute highlights of ongoing immunization projects, and then we'll have some time for question and answer and moderated discussion. And then second, we welcome your feedback, especially as this is a new format for us. So please take a few minutes at the end of today to fill out our evaluation so that we can continue to grow our Accords highlights in a way that meets everyone's needs and hopefully brings people together around the work that we're doing in Accords. Okay. It is truly an honor today to introduce our two speakers. We have Dr. Sean O'Leary and Dr. David Higgins with us today. And I am just thrilled to be able to highlight a topic that is near and dear to my heart and a team that has been just an honor to be a part of over my almost 15 years at Accords. So first, we have Dr. Sean O'Leary, who's a professor of pediatrics in the University of Colorado School of Medicine and Children's Hospital Colorado. He's a pediatric infectious disease specialist, an investigator at Accords, and the director of the Colorado Children's Outcomes Network, which is Colorado's pediatric practice-based research network. He has over 230 peer-reviewed publications, and his primary area of research focuses on prevention of vaccine-preventable diseases through understanding clinical, attitudinal, and infrastructural barriers to vaccination, developing and testing interventions to address those barriers. Much of his recent work focuses on studying how best to communicate about vaccines in clinical settings. He's a member of the AAP Council on School Health and serves as chair of the Committee on Infectious Diseases for the AAP. He serves as a liaison to CDC's, well, until recently, served as a liaison to the CDC's Advisory Committee on Immunization Practices, and currently represents the AAP on COVID-19 and RSV work through that. He represents the Infectious Disease Society of America, also on the HPV working group, assuming it ever meets again. He also serves as a co-chair of the Policy Committee for Immunize Colorado and director of the National Foundation for Infectious Diseases as a member of the steering committee for Voices for Vaccines. A lot of work in this space. And then second, we will hear from Dr. David Higgins, who's a double board-certified pediatrician and preventive medicine public health specialist, whose research focuses on improving vaccine delivery and communication. He brings experience as a community pediatrician, academic physician, public health advisor, and health services researcher at Accords, with expertise in medicine policy, health services delivery, disease prevention, and education. Dr. Higgins trained in pediatrics at the University of Washington in public health prevention medicine at the School of Public Health after earning his MD from the University of Colorado School of Medicine. And I particularly want to highlight that Dr. Higgins also recently completed our primary care research fellowship at Accords. So thank you for joining us today, and welcome, Dr. O'Leary.
Hi, everyone. It's a pleasure to be here. Yep. Yeah.
The Zoom screen is frozen.
Oh, that's no good.
We'll see if that.
Okay. I think it might be on David's to start. I was gonna go first. There we go. Okay. All right. Pleasure to be here. I will say I won't be talking about the huge elephant in the room around everything going on with vaccine policy right now. I will say those ACIP, I'm still on the website, but I don't know if I'm officially invited anymore. But anyway, yeah. Okay. So I will just kind of dive into my slides and try and keep an eye on my time. I'm going to do my best to highlight, I think everyone that works in the research world understands how much effort and work goes on the part of the whole team, and how much we spend our time doing these things. So I'm going to do my best to summarize several projects that have happened over the last decade in roughly 20 minutes or so. And Russ is sending us a nice joke, it looks like. Thanks, Russ. All right, so I have no disclosures. So my objectives by the end of this presentation, I'm hoping you'll be able to describe the current state of research in clinician-parent vaccine communication in primary care settings, and to be able to explain evidence-based communication strategies that clinicians can use in vaccine conversations. And to do that, I'm going to go through some background. And then I'm going to talk, this is where the meat of it is going to be the second bullet there, current, recent, and future clinician communication interventions. And then finally, translating some of that research into community settings. So I'm going to briefly go over the problem here. I think everyone's aware we're in perilous times for vaccine coverage here in the US. This is just one source of data. On the y-axis, you have the percentage of kids who are up to date for what they call the Combo 7 vaccine series by age 24 months. It's a common metric for measuring up-to-date status of children. And on the x-axis is birth year. And you can see that we've fallen from roughly 70% of children by age 2 being up to date for birth year 2017, 2018 to about 67% for those born 2020, 2021, and there are new data coming on this now, and it's even lower now. We also know that the proportion of parents claiming an exemption from required kindergarten vaccines is going up. Now, it's still a relatively low number. It's actually 3.6% this year, but that's still the highest it's ever been by quite a stretch. So you can see pre-pandemic here on the left, the number of, these are the percentages of parents claiming an exemption pre-pandemic by state. And you can see there's kind of I'm colorblind, so forgive me if I'm getting these colors wrong, but what I think is green, that the bulk of those states at less than 3%, 28 states. And then on the other end of the spectrum is that kind of blue color greater than 5%, that was 8 states pre-pandemic. And then on the right, what you're seeing is basically that it's gone up everywhere, the percentage of parents claiming exemptions. And in some places, those are the percentage of parents claiming exemptions is actually well over 10% in certain states from childhood vaccines. Now, we could talk the whole hour about data on vaccine hesitancy, but what we're here to talk about really is what can we do about it? And so one solution that our group here has been focusing on is clinician communication. And you know, one reason I landed on this, Sarah didn't, I didn't have this in that bio, but I was a primary care pediatrician for about 8 years before I came back and did an infectious disease fellowship. So I've, you know, kind of had the sense when I was doing when I trained as a resident, I really didn't get much training in about how to communicate about vaccines. And so I didn't really, when I went into practice and I found parents, you know, questioning vaccines, refusing vaccines, I was at a loss. I really didn't know how to handle it. And that is kind of how I ended up in this space. So what you see here on the left on this slide is parents were asked, these are parents who had refused vaccines and then they decided that they would get their child vaccinated, and they were asked what was the most impactful thing on their decision to vaccinate their child. And by far the highest was information or assurances from their child's doctor. So we know that clinician communication is really important. On the right, this is a more recent study. That study on the left was done roughly 20 years ago. So on the right, what we see is from during the pandemic, willingness of parents to get their child vaccinated after talking with their child's doctor. And you can see close to 40% reported they were more willing to get their child vaccinated against COVID. And so we know that clinicians have a huge influence on getting their children vaccinated. So now moving into some of the work we've done here, gosh, I think we started this project over 10 years ago now. This was a study, this is the final publication of the study of the main outcomes. We called it the Physician Communication Study. And I'm going to go into a little bit of detail on this one because this was the basis of some of the other work that we've done. So this was the official title of the study was Strengthening Provider Communication for Increasing Uptake of HPV Vaccine. It was a CDC-funded U01 cooperative agreement. It was a cluster randomized trial among 16 practices here in Colorado, both public and private, primarily pediatric, but we also had family medicine. And it was what we would call a multi-component intervention. It had several arms, but it also included training in, and I'm going to explain more about both of these things, a presumptive vaccine recommendation as well as motivational interviewing. So what do I mean by presumptive? So, and there have been observational studies as well as randomized trials showing that there is some benefit to using this presumptive format for initiating vaccines. So this format assumes that, linguistically assumes that parents will vaccinate. So instead of saying, how do you feel about vaccines today? You would say, so she's due for several vaccines today, or Sarah's going to get 3 shots today. And that's been shown both, again, in observational studies and randomized trials that it may increase uptake of vaccines. And then motivational interviewing, I'm sure there may be some MI experts in the audience. I'm just going to give one example of what motivational interviewing might look like in the vaccine setting. So the parent might say, I know shots are important and all, but I'm just too worried about side effects. And then the clinician might say, you want to be sure these vaccines are safe. I get that. I also hear that you appreciate that vaccines are important. Tell me more about why you think shots are important. So that's just one skill that we were teaching. And I'll go into a little more detail on some of those skills in another slide. So the high-level results from this initial study on vaccine communication One, we saw that self-efficacy for changing parents' minds about HPV vaccine improved among clinicians. We also found, because we know that clinicians have, the average well child visit in the US is 18 minutes. And so we really have to be careful not to extend these conversations and make them long. So we wanted to make sure that we trained them to be effective, but also efficient. And so the time spent in these conversations was the same or decreased from baseline at 4 months after the trainings in the intervention clinics. So that was good. And then where the rubber meets the road, we had an almost 10% increase in HPV initiation in the intervention practices versus the control practices. And that's actually a pretty big effect size for this type of a study. So this was some of the evidence base for the use of both presumptive recommendations as well as motivational interviewing in the vaccine communication space. And in some ways, the cart has gotten a little bit before the horse. A lot of both national and international organizations now recommend both presumptive format and MI in vaccine conversations. CDC, AAP, WHO all recommend these techniques in vaccine conversations. I would say there's quite a bit more work to do to really understand that, and I'll get into a little more detail on that in a minute. So this study, the PCOM study, led to several other projects, and I'm going to touch briefly on a couple of these and expand more on that second bullet, Pivot with MI, which I think I can thank Sarah for that acronym. If you need an acronym, Sarah's your woman. The better than ChatGPT by far. Anyway, so MI for MI is motivational interviewing for maternal immunization. I'll talk briefly about that. Pivot with MI, presumptively initiating vaccination and optimizing talk with motivational interviewing, and then the PCOM2 study. So MI for MI, so this was motivational interviewing for maternal immunizations. This was an R21, a smaller grant, 5 obstetric clinics in Colorado. We trained clinicians in vaccine communication, including use of presumptive format and brief MI skills. Our kind of high-level results were that the healthcare providers reported better experiences talking about vaccines and reported they would keep using those skills in the future. We did a mixed methods evaluation using the PRISM REAIM frameworks, and these are some of the publications from that study. We have submitted other grants that are kind of in limbo on this one for a variety of reasons. But anyway, so that's the MI for MI study. And then PCOM2, this is a study that we're in the midst of right now. So we called this the Physician Communication Intervention version 2.0. So remember, I talked about the PCOM study. So what we did with this one, this one's funded by the National Cancer Institute. It's a non-inferiority study. So we're comparing the original PCOM intervention, which was in-person communication trainings, versus a virtual communication training, with the idea that a virtual training is going to be much more scalable. Our primary outcome is initiation and completion of HPV vaccine series by age 13. We're working in 22 pediatric and family medicine practices in Kansas. We have a smart trial design. So in the virtual arm, if they don't demonstrate what we call mastery, the clinicians within these practices, they get randomized to either further training or not. And so we're also doing a PRISM REAIM evaluation with that study. We are, at this point, all the practices have completed the trainings, and we should have some study outcomes next year. Now, Pivot with MI, I'm going to talk a bit more about this because this is the basis for some future work that is going to be happening hopefully fairly soon. So this is a cluster randomized trial that we recently completed. It was among 24 practices, both here and in Washington. Our pediatric practice-based research network here, so it was all pediatric practices in this one, as well as a pediatric practice-based research network in Washington State. So this one was about the infant series. So the other ones I've been talking about have been either maternal vaccines or HPV vaccine. This one is about the infant series of vaccines or the early childhood series. And surprisingly, there have not been a lot of studies looking at communication interventions for the infant series. So this is one of the first that was an actual large cluster randomized trial. So we trained intervention clinics in the use of presumptive format with all parents, with the idea that they would pivot to motivational interviewing for those parents who continue to refuse or express concerns. And we tested the impact of this tiered vaccine communication strategy on childhood vaccine uptake by age 19 months. I'll go into a little more detail on the outcomes of this study. So the tiered communication strategy, as I mentioned, start with the presumptive. Today, we're going to do 2 shots. And then the parent can either refuse vaccines or express concerns. And then we train the providers to use some motivational interviewing techniques that I'll show you on the next slide. Or they just agree and then you vaccinate. And believe it or not, most parents actually agree when you just use a presumptive initiation format. Most parents are actually accepting of vaccines, despite what we hear in the news. So the skills we teach, some people might label this brief motivational interviewing. We tried to keep it very concise. So open-ended questions, affirmations, reflections, autonomy support, and asking permission to share, which I think MI trainers would probably call elicit, provide, elicit. So our primary population was parents of infants under 2 months. We wanted to really focus on vaccine hesitant parents, not just all parents. And so we measured their vaccine attitudes, defined as a score of greater than or equal to 2 on a validated screening survey. So this is called the PAC-V. So basically, this survey has been highly validated to predict future vaccination behavior. How you respond on this survey predicts what you're going to do with your kids in a very accurate way. And you can see here kind of the questions that were in that survey. And I'll talk more in a minute about how we administered that survey. So again, primary outcome, receipt of these 8 routine vaccines by age 19 months. And our primary outcome was actually kind of an interesting metric. It's called days under immunized. So a lot of studies will use up to date. We used days under immunized because it's a little bit more sensitive and it captures both vaccine receipt and whether those vaccines were received on time. And so that's calculated by comparing the data dose received to when it should have been received using the child's date of birth and the vaccine schedule. And so the range is either 0, so you're on time, or 2,830 days late when you add up all those different vaccines. And so then those 2 outcomes that we looked at were the % days under immunized, as well as 0 days under immunized, what proportion of kids were completely up to date and on time. So this is showing participation rates in our curriculum, because of course we wanted to track and make sure that, what we were training people in, they were actually doing and participating. And you can see overall, so you can see all the intervention clinics listed on the left there, just drawing your attention to the bottom. We had a video module, so 92% viewed the video module, 93% attended or viewed the baseline training, 82% attended or viewed the first refresher, and then 77% attended or viewed the second refresher. So we were encouraged, pretty high participation with that one. Now, this is where you're playing the video game and the Pac-Man dies, because we got our results, and this was overall for our primary outcome a negative trial. So you can see intervention versus control. Our adjusted incident rate ratio for the % days under immunized was roughly close to 1. Now, the % 0 days under immunized, and I'll go into this in a little more detail, was above 1, although it did not reach significance, and I'll talk more about that in a second. We did see variation across the states in that up-to-date on-time result. So overall, again, you can see on the left 1.45, but we also saw that it seemed to have an effect in Washington, but not Colorado. We have some ideas about that, and I'll show you that on another slide in a second, I think. But couple interesting things as we dug more into the data. So this is the proportion of children in each study arm with 0 days under immunized by parent hesitancy level. So the y-axis is the proportion of parents. The x-axis is your score on that PAC-V that I described. 0 means you are not hesitant at all. Your doc tells you to get a vaccine and you get it. 4 is pretty darn hesitant. And so what you can see is that for those parents that weren't very hesitant comparing intervention or control, those that were at 0 and 1, there was kind of a striking difference there in the kids that were, the % of kids that were up to date on time. As we get further out, that difference held a little bit, except when you get to the most hesitant parents, where you can see essentially none of the parents in the intervention arm who scored a 4 were up to date on time, as opposed to 5% in the control arm. So just to summarize our study effects, we didn't see overall an effect of the intervention among parents with these negative vaccine attitudes. One of the issues we ran into, and this is getting a little technical, but our class correlation among the practices was much higher. It was 0.09 than both our power calculation and our prior studies. We've sometimes used an ICC of 0.01 in these power calculations and found that in studies, but it was much higher. So I think that blunted some of the effects. We have some ideas about that. There were 1 or 2 practices in both states that had really high levels of vaccine hesitancy that we think may have driven some of these results. The effect of the intervention, though, again, varied by state and by hesitancy level, as I mentioned before. So these are the publications we have from this study so far. We have a few more coming, and we have published the final primary outcomes as well. So what are the next steps? So, of course, the problem is we don't know really the implications for clinical practice from our Pivot with MI study. It's a bit difficult to separate out the effect of the presumptive strategy versus training clinicians both in a presumptive initiation format and motivational interviewing. Having done, David, Sarah, and I have done, dozens, if not hundreds of these trainings, it's actually much easier to train people in just a presumptive initiation than it is motivational interviewing. It takes a lot more time. So should we really be training people in motivational interviewing if we can't show that it actually works? So the opportunity is, of course, we clinicians need these evidence-based strategies for improving childhood vaccine uptake. So we want to understand the effect of training in the presumptive format alone versus the incremental benefit of potentially adding motivational interviewing training. We're also looking to do this at the national level. So that's leading us to what we're calling Pivot plus minus MI. So this is a study that has been planned and accepted by the AAP's practice-based research network. It's called PROS, or Pediatric Research in Office Settings. It's a very large, I think it's probably actually the largest practice-based research network, hundreds and hundreds of practices across the US. And so we're going to enroll parents with negative vaccine attitudes at PROS practices and then randomize to presumptive only, presumptive plus MI, or usual care. And then again, we'll look at childhood vaccine uptake. And this would be the first study to assess the effectiveness of the presumptive format alone in the childhood vaccine context. So this is just our training curriculum, very similar to our other trainings, but we really wanted to keep this as practical as we could. So as you can see, we're making these trainings very, very short for the clinicians. And then you can kind of see what we'll be doing here in year 1, adding the presumptive only criteria and then revising our existing Pivot with MI curricula. And then we'll pilot that, and then we'll do the randomization. So, and for almost all of these studies, we do offer clinicians, particularly physicians, MOC Part 4 credit upon completion. And then we try to get CME and CNE for the other clinicians. So our methods, again, 3-arm cluster randomized trial, clinicians using the presumptive format. Then just if the presumptive format doesn't work, they do what they normally do. A lot of these clinicians are really highly skilled in these vaccine conversations on their own. And then for the presumptive plus MI arm, those clinicians will have had the additional MI training, and then there will also be a usual care arm. So our sample size is 60 total practices with 20 practices per arm. We're looking for a 10% effect size in the percent 0 days under immunized, and we'll have 80% power, assuming an ICC of 0.05. So we kind of split the difference between what we historically have seen and what we found in our particular study, thinking that it's going to be more consistent with what PROS has seen before. And then we have some exclusion criteria as well. Again, so our primary study population, English and Spanish-speaking parents, have an infant under 2 months old receiving health supervision, and then have negative vaccine attitudes based on the PAC-V. And so I mentioned I would talk about how we did that. So the PAC-V is incorporated in the check-in paperwork handed out by the clinic staff to all parents at the 2-month visit, and includes the PAC-V and then some demographic questions. In our Pivot with MI study, and we've seen this in other studies as well, about 1 in 10 parents had screened positive with a PAC-V score greater than or equal to 2. And interestingly, that has been very stable over time, if you can believe it. I'm not going to go into this in the interest of time, but our next steps are our letter of intent to PCORI in September that we're mostly done with at this point. So just to finish up really quickly, translating the research into QI in the community. This was a project that Sarah, David, and others quite a few others were involved with our state health department. So this was based on the fact that we're seeing falling kindergarten vaccination rates in Colorado and, oh, by the way, measles. And so this was done July 2024 to just this past June. And we had two different projects going on here. One was a series of online vaccine communication training, similar to what I described with Pivot with MI. And then we also did a rapid boot camp translation that I won't go into detail with, that Sarah led, that was Sarah and Amanda Skenador led, that was very active group of boot camp translations. So for the online trainings, we had 33 enrolled practices with 155 participating clinicians. And then for the BCTs, we had 3 separate ones, the Western Slopes, Steamboat, and Denver Metro. Also had 7 practices involved, two school districts, and that was across 4 different counties. We also recently, it's in fact going on right now, and the last training will happen this week. Our team has been working on a national AAP ECHO series that's funded by the National AAP. This is a series of 3 90-minute ECHO trainings on vaccine communication with pediatricians across the US. We did our first 2 trainings in July and August, and we have our last training this Wednesday. And then finally, this was a clinical report for the American Academy of Pediatrics on strategies for improving vaccine communication and uptake. You can see I was an author on this, as well as Doug Opal, who's a major collaborator of mine in Seattle, and then Jessica Taldi, who's also here at Accords and Children's. And a lot of the work that all of us had done went into this report. And so just some examples of what's in there, if anyone wants to read more about sort of how to communicate about vaccines. We have a table of vaccine safety surveillance systems because we know vaccine safety is a concern. We had a table of myths and misconceptions. And then we also, directly from our Pivot with MI trial, we had a figure on vaccine communication that I won't go into detail, but it's kind of an algorithmic part of the presumptive format, but then and then also tips on how to use MI, which is sort of the opposite of an algorithm. And you can kind of see a little more detail here. We also give presumptive pearls on what's a good way to do a presumptive recommendation. So I will stop there and turn the floor over to David. And I'll leave up here our team, because this is, we have a lot of people working with us on this. Thank you.
All right, great. So I'm glad that I'm going second, because what I'm going to do now is bite off a little piece of what you just saw and reference some of those things, but talk about something that's been a line of inquiry that's been brewing in my mind for over a decade as I practiced in the community, and now continue to see patients in clinic. And that is what happens before the clinician patient-parent encounter. No disclosures from me. And really what I want to do here is describe what we know and understand about the current roles for health professionals, this big umbrella of health professionals that interact with families before the clinician walks in the room, and potentially identify some strategies and interventions or what we need to know, look into more. So quick roadmap. I want to demonstrate the problem, talk about some potential approaches, and like Sean just said, I think in this area, we're putting the cart before the horse even more. But it's already running, so we're trying to run with it. And then I want to describe the role of these clinical staff in vaccine communication and next steps and opportunities. So this is from the clinical report that Sean just shared. In it, it says front desk staff, medical assistants, nurses, and other staff often play a major role in vaccination processes. So engaging all team members in the office setting or inpatient unit who communicate with parents about vaccines on the rationale and technique for initiating the vaccine discussion could maximize its effect. And for many reasons, this makes intuitive sense, right? These team members already are central to vaccine delivery. They have a lot of contact with families. We know from other preventative care measures, quality care measures, that a team-based approach improves quality of care and health outcomes. There's also the potential that there's greater sociocultural concordance with parents and some of these staff than sometimes the clinician or physician. Additionally, they're community members, and sometimes they are in the communities in a different way than, say, the physician is, and they can reinforce vaccine messaging beyond the clinic walls. Okay, so here's the problem, right? I heard this a lot, okay, and continue to hear this. I'm out, typing on my computer, finishing notes, and I overhear my MA say something like, hey, we have the flu shot if you want it this year, but it's not required for school. And the parent says, well, I don't think we want that one. And the MA says, okay, I'll let the doctor know. And they come out and they tell me, and they say, hey, they don't want the flu shot this year. And and I do want to point out that I'm not singling out these staff. I see physicians do the same exact thing all the time, okay? But my interest in this area is, for years, I've wondered, okay, this completely changes the dynamic of the conversation that I'm about to go into, right? The parent has already voiced an opinion and received a response to that opinion about getting the vaccines. I'm entering it in a different place. So years ago, I went to the literature and said, okay, what do we know about this? And we know nothing. I mean, really, there is nothing out there about what these team members should be saying, what they do say. Really, the landscape is wide open here. So some of the questions that have been in the back of my mind for years now is, okay, first, do staff communicate? Like, is this just a thing I'm noticing in clinic, right? Anecdotal evidence. And if so, what are they saying? Okay, and what opportunities exist for these staff to more effectively communicate? How does it shape the clinician-parent conversation or clinician-patient conversation in adults? And what interventions could enhance effective vaccine communication? So first, I want to talk about a small pilot project. I received money from the American Academy of Pediatrics to do this QI project. And in this project, I adapted and implemented PCOM. So PCOM was that physician's communication training that Sean just talked about on HPV vaccine communication. And I adapted it and implemented it for the entire care team, really intentionally bringing in all the non-clinician staff, okay? So those include anybody who's not a physician, a physician assistant or nurse practitioner. And in the course of doing this, I used several different methods, including an advisory group that consisted of all those different levels of stakeholders. And we went through a process of adapting the curriculum so that it fit the needs not only of physicians, but of some of the other members of the team. Went through, created the adapted curriculum, and then implemented it in the trainings. And I'm not going to go through a lot of detail, but I just do want to point out in this project, I had two practices. There were actually 4 clinic locations. And one of them was on the Eastern Plains. One of them was on the Western Slope. That wasn't on purpose. They just happened to be kind of on opposite ends of Colorado. One was predominantly VFC eligible, and the other had a high proportion of VFC, and that's Vaccines for Children program. And so that's a program that gives vaccines for public insurance children or children that are uninsured or underinsured. Okay, so that gives you a sense of their public insurance population. And what I found after delivering this adapted training was that the non-clinician staff, they felt more confident in making a recommendation. They thought it was valuable to receive this training, and they really thought it was relevant and applicable to their role. At the same time, there were some really striking differences between these practices, which illustrates the challenge of this type of pragmatic research and these pragmatic interventions. In one of the practices, the medical assistants and nurses, they really just wanted basic foundation in communication. They wanted scripts. They just wanted, hey, when a parent says this, what do I say? Okay, really simple. They didn't want motivational interviewing training. They didn't want any of that. In practice 2, their MAs and nurses have standing orders to give vaccines and frequently give vaccines before the clinician even gets in the room. And so they wanted the whole training. And that was really important to them. So it's important to recognize that clinics use these health professionals in lots of different ways. And so if you go into practice 2 and you only train the clinicians, you might not even be training the people that are having most of the conversation with the families. Okay, so these are the 3 products that the 3 projects that Sean just talked about. And I want to point out, this is where the cart's getting a little bit before the horse, but we're getting asked, okay, what should our staff be saying? And so we have created some materials really extrapolated from what we know and what we're learning in the physician world to these other professionals. And we are saying, use the presumptive approach. Okay, we train them and say, have your MAs and nurses and other staff use this same presumptive communication skill. And we are training the physicians and clinicians on kind of how to respond when you find out that there's some hesitancy from the family. But here's the problem. Is this the right approach? We really have no idea, okay? Because we are getting the cart before the horse here. So several years ago now, 2 years ago now, I received one of the generous Ergen pilot grants to investigate this. And the objective with this is to just get a sense for what is currently happening in pediatric primary care in several clinics and describe it more. So in 2 clinics in the Denver area, they're both large clinics. One's a private clinic that serves mostly privately insured patients. The other is a nonprofit clinic serving mostly Medicaid children. And we went in and did direct observations. We watched medical assistants and front office staff from all the communication that happens from the minute they walk in the door until the minute that the clinician knocks on the door for the encounter. We also did interviews of MAs and clinicians as well. I won't linger on this too long, but this is just a process map to illustrate kind of all of the different steps in the process of checking in and getting the patient ready for the encounter where communication occurred about vaccines. And sometimes these were small little comments. Sometimes these were detailed conversations. And what we found was that vaccine communication occurred. Frequently, there was something said. This was sometimes initiated by the parent. This was sometimes initiated by the MA or the front desk staff, okay? Vaccines were frequently recommended in some form or fashion from the non-clinician staff. However, the presumptive type format was inconsistently used. I will say there were times where the presumptive format was given better than I hear clinicians do it. And these are just some key observations here, right? So for example, sometimes they would say something like, Johnny's due for HPV vaccine today. Do you want to do it? Which is a little bit weaker than saying, she's going to get her second hepatitis A vaccine today. There are also differences in communication styles for non-influenza and influenza vaccines. We didn't separate out COVID-19 vaccines. We essentially saw nobody recommend these, which is a whole different thing we can talk about. But for what we noticed a lot of, they're due for this, and if you want, you can get the influenza vaccine, kind of separating it out there. In interviews, we're still compiling all of this data, both in the MAs and clinicians. But what we found was that the MAs really like following a set protocol. I think that's actually an advantage, right? They want to know what they should be saying. And I think that lends itself to easier interventions, okay? Where sometimes with my experience when training the clinicians, they're less receptive to that. Whereas we found with the MAs, they really just wanted to be told what to say. How do I respond to this exact question? And often MAs are learning this on the job, right? We talked about how in residency, we didn't get this training. Now there's a little bit more incorporated into undergraduate medical education and residency. But for MAs, really university, they said they didn't receive any training in what to say about vaccines. And when we talked to them in interviews, it confirmed what we've seen in other places, that the additional training would be really valuable for them. Okay, so what are the next steps? Well, that was small. That was 2 clinics, right? And a little bit more in depth, the direct observations I think were really important, because if you all know when you do this type of pragmatic work, what they say they do on a survey and an interview is not always what they actually do. So it was great to get those, but we need kind of information across, to be able to generalize, we need information across more clinic sites and types of clinics. And so right now we are wrapping up this project. This is a survey project. We received a small pilot grant to survey the 22 clinics that are involved in the CCOM. And up here at CCOM, it's the same as PCOM 2.0. I know we changed the name partway through, which confuses people a little bit. But in this, we are we surveyed all of the nurses and medical assistants at the 22 practices, really to get a sense for, okay, what are their knowledge, attitudes, and practices, current practices around HPV vaccine communication and recommendations. Don't have the data on this yet, as we just closed the survey. We have a great response rate and plenty of responses, so I'm hoping that this survey helps us to get a better generalizable sense for what's going on in clinics with these non-clinician staff communicating about vaccines. So there's still some questions to answer. I think one of the biggest ones is, how does staff communication shape the clinician-parent conversation? Right? And in future research, I really would like to look into that more. Is what they say priming the conversation in a negative or positive way that the clinician is about to have? And how influential are the things that these staff say prior to the clinician entering the room? We often talk about how a recommendation from a physician, some surveys say health professional about vaccination is the most important thing in predicting whether a parent's going to accept a vaccine. But we don't have data on specifically, how about these health professionals? How do parents see their recommendation? And then if there is evidence that, hey, this is something we could improve and therefore improve uptake, what interventions could enhance this? These staff often have, as any of you that have worked clinically or worked in clinics understand, there's often a lot more turnover in these staff. They have a lower level of understanding of things like vaccines in general, because they don't have the same level of training as a physician does on the background of vaccines. So I think in my experience, they are less interested in handling myths about vaccines and things like that, because they don't have some of the background knowledge to be able to answer some parents' questions. They still may be able to answer it in a way that primes the clinician when they go in and answer those concerns and questions. So I had a K application in to continue this work at ARC, and I don't really know what to say other than that. And you all know what's going on with the NIH right now. So this is obviously a challenge. I consider myself incredibly fortunate, though, to be here at Accords, to have gone through the primary care research fellowship after being in practice for years, and have an incredible team of mentors and people doing this work, to move forward with this. I don't want to end on that, because I am an eternal optimist. So I think there are a lot of opportunities here, right? First, I spoke about medical assistants. I spoke about the primary care setting. I think there's a lot of opportunity for collaboration across health professional fields here. If you think about the big giant umbrella, the giant tent of health professionals, this includes community health workers, patient navigators, dentists, dental assistants, pharmacists, social workers, public health nurses, all of these people. And in my utopian world of vaccine communication, all of these people would have a consistent message. It might be different depending on who they are and how they deliver it, but all of them would be consistent. You already saw examples that Sean shared of training and QI and capacity building that we have been doing already. Again, I think that there is a lot of potential here for integrating this into their normal processes that these staff are doing, and then also really leverage the fact that the staff represent sometimes a different part of the community than the physicians do. And I think that's really important in vaccine equity and equity in communication about vaccines. So my acknowledgements are essentially the same as Sean's. You can keep looking at these, but I do just want to highlight Sean and Ali Kemp, who have been incredible mentors in helping me answer this and launch the research part of my career. Sit up.
Wait, is this one working? Yeah, excellent. Thank you both for sharing really like 2 decades worth of work. It's amazing. One of the questions I want to ask the two of you, you both brought up some work that's really grounded in observation of what's happened in clinics, and I think for physician communication that really drove even the presumptive approach as an intervention possibility. And you highlighted really in-depth watching of what other staff are doing. And I'm curious, one, how you came to what we often see as inefficient ways to collect data because they do take a lot more time. And then maybe a little bit around kind of the added benefit of putting in some of that extra time to get there on some of the data you've collected in the space.
Sure. One of the things I didn't mention is, yeah, okay. Oh, you didn't put Portland State up there, did you?
Oh, yeah.
Yeah. So on several of these studies, we have worked with a guy named Jeff Robinson, who is I believe originally trained as a sociologist. He's the head of the Department of, I think, Communications at Portland State. And he is what's called a communication analyst. And so or a conversation analyst, I should say. And so he had started with Doug Opal, oh gosh, 15 years ago now. They had done videotaped observations of these vaccine conversations. And one of the things I've learned from Jeff over the years, and the data really, the literature really supports this, is that what clinicians say, and what patients say, or parents, after an encounter is often very different than what they've actually said. And so Doug and Jeff and their team were able, that was sort of where they made that original discovery about the presumptive recommendation being a potentially effective communication strategy, because they were able to videotape over 100 vaccine encounters where the parents and the clinicians thought that they were told that they were just studying well childcare, not specifically vaccine conversations. And they were also able to oversample vaccine hesitant parents in their sample. And they were able to show, at least in this observational study, that using a presumptive recommendation in the vaccine conversation was highly predictive of vaccine uptake, both in the hesitant and the non-hesitant parents. And then there was a follow-up RCT that was done, and then it's been incorporated in lots of places. So with that in mind, a lot of our studies we have used either videotaped or audio taped encounters, which are incredibly challenging to get done practically. Like in Kansas, it's all over the state, and we've had 2 research assistants there who have just done an amazing job going to all these different clinics and being able to do these. For that project, we're doing audio taped encounters. For our Pivot with MI study, I didn't mention it, we had originally planned to do 300 videotaped encounters. Pandemic. So we were not able to, because of the pandemic. It was right in, gosh, I think we were starting to do these in December or January of 2021 or something like that. And so the university was not allowing anyone to go into clinics. And so we were able to, once that rule was lifted, we ended up getting about 30. And so we're going to be able to analyze those and report on those, but we're not going to be able to really describe as well as we would have liked fidelity to our intervention. But all of that to say, yes, we try to collect as much data as we can on what's actually happening in these settings. And frankly, we learn an awful lot from that. I mean, remember, a lot of these clinicians have decades of experience having these conversations with families. And we see like, wow, yeah, that seems really a really powerful thing to say in these conversations. And so we do learn a lot from those.
Yeah, and sometimes decades of experience means that they're set in their ways and maybe don't always say things the right way, but that's how they've done it for 25 years, and so they continue to do it. And I agree completely that it's necessary, it's hard, and it's necessary. I think for me, after my own experience anecdotally observing and then doing observational work in research, without any observational work, I don't even trust just the survey type stuff, just asking people what they do. I don't trust it without it being backed up in some way by real objective data. And that's usually going to mean observation, audio, video. Vaccination rates and downstream effects matter, right? And so if you get those, okay, we're doing something here. But I think it's just so important because time and time again, they say they're doing something and then you watch it and you're like, that wasn't actually what you should be doing.
Can one or both of you talk about the format of your training? I know you're testing sort of virtual versus in person, but can you talk about generally how most of the communication trainings are happening?
Yeah, so that's evolved over the years. When we first started that first project I described that started over a decade ago, We worked with a woman named Kathy Garrett, who was a really experienced MI trainer here at the university. Did a lot of work on smoking cessation. She hadn't really done any work in vaccines, but she was really excited to do it. And so we partnered with her for that project. And for that project, Kathy was at every training, and with having, one of the rest of the study team as a sort of a co-moderator. And so those were so we had kind of a video module introduction that goes over sort of the brief overview of what we're going to be training them in. And then we would have an initial in-person training where initially it was much less scripted in that first study, where Kathy would kind of a little bit fly by the seat of her pants in terms of training people in MI. And we built the training. It was kind of an iterative development through the training of these different practices. And then in more recent studies, we're really kind of getting a lot more scripted in terms of what the trainings, what we say in the trainings, what the slide, like more involved slide sets, and trying to keep them as uniform as possible. Trying to make the in-person trainings for that one study where we're comparing in-person to virtual. We've also now partnered with a guy named Steve Waddell, who's up on the slide, who's at a place called CTE Learning in Kansas, who does a lot of really cool work. He hadn't done much in the world of vaccines either, but was very passionate. But when we approached him, he was very passionate about HPV vaccine and was excited to work with us. And so he had done a lot of different trainings in different environments, everything from high school students to training physicians to training college students, all kinds of these different virtual trainings. He's actually incorporating a lot of AI into some of his virtual trainings now. And so we've been working with him to really get these virtual trainings as interactive as we possibly can, trying to create asynchronous virtual trainings that can then be easily scalable. So it's really been a variety over the years, I would say, in terms of how those trainings actually work. The in-person trainings are, at least the evidence so far is that they're probably the most effective because you get the most engagement, but also very challenging to do at scale.
This question, I think, was directed at you, David. What do you know about the effect of gender, race, or ethnicity of the clinic staff on the influence of their communication or the effectiveness of those communication strategies with the patients they see, and particularly whether like matching of race or gender, ethnicity might influence that communication?
Yeah, so the answer is not much yet, but I think that it's really an important question, along with things like socioeconomic status and income and things like that. I think that I don't want to make a hypothesis either way because I'm not sure. We need to do research on how those dynamics, like I said, the concordance between some of those things, between the staff and the parent or patient. I'm not actually sure which way that might influence the conversation, but I think it's really important to explore more that influence.
I'll just add something to that really quick. Sort of in the more broader context is that in some ways this field is really in its infancy, and one way that it's very much in its infancy is how these different communication styles impact different populations. And there's a large body of literature on motivational interviewing in general for things like smoking cessation, and there have been some studies looking at how it impacts different populations. We have almost nothing on that in the vaccine space, and so that's work that hopefully we can do over time.
We have time for one question. I'm going to let Alyssa see. She's been on the edge of her seat to ask.
I'm very excited. Alongside that question about matching identities for patients and providers or assistants to providers, I have a broader question about provider trust, provider-patient trust, because in motivational interviewing, to true to form, really conditional positive regard and good rapport is foundational for the strategies to work. So are you guys measuring that in specific ways in the study? Are you using that as covariates or moderators? Because I would expect that might account for a ton of the variance, especially in situations where the identities may or may not line up?
Yeah, really great question, and something that needs to be addressed and studied. I mean, I think so. One of the major variables in all of this type of thing is very difficult. Well, trust you. There are validated measures for trust, but the other piece of that is the relationship that a clinician has with a family, right? And so it's a very different conversation if I'm talking to a family I've known for 10 years, I've taken care of 4 of their kids, and this is their 5th kid, and they come in with some nonsense, versus somebody I'm meeting for the first time. And in the first example, you could, often just say, you know what, don't worry about that, it's fine, and then they're going to vaccinate. In the second example, where you've never met the person before, does motivational interviewing actually work in that setting? And we don't know the answer to that question, but it's an important question.
And I will just add on to that there's a lot about communication, building rapport and trust that doesn't come out in surveys, doesn't come out sometimes in audio visits, right? Sean threw up the pearls briefly, right? Are you sitting down, right? I mean, we know from the literature, from evidence that like if the clinician sits down, the patient thinks that they spent way more time with them, right? And so there's all of these types of nonverbal communication things that I think really matter. And I just want to share one anecdotal story that highlights this. One of my wonderful nurses up in Montana, when I was working in primary care up there, she had been in the community for a very long time, took care of the parents of the kids when they were kids, right? And then the kids. And her approach was when they would come in, she would say, "You're going to get the flu shot today." And she would like look them in the eyes and they would be like, "Yes, ma'am." Because she had so much trust with that community, right? And with those people, she could do that. She wasn't the doctor. And so I think some people would bristle at that and say, well, should she be doing that? She had so much trust. She said, "You're going to get the flu shot today because it's really important." And they would say, "Okay," right? And it's only because she had that trust. And she wasn't one of the clinicians. She was one of the nurses.
I want to thank you both again for being here today. And I want to thank all of you for being here on Zoom and in the room for our first Accords highlights. If you're here in the room, there are evaluations on paper over there, and we do really appreciate your feedback. Thank you both.